Hello and welcome to this live event this evening. It's a huge pleasure to be here with this whole host of wonderful women in interventional radiology here in the UK, celebrating the week of International Women's Day on Sunday, and a huge thanks to the BSIR, the British Society of Interventional Radiology, and specifically their EDI committee for putting this event together. This is an annual event celebrating International Women's Day. This is the third year that we have put an event like this together, and it's a privilege to be part of the group this evening. I'm really looking forward to the conversations that we're going to have together over the next week, the next hour, talking about our experiences in interventional radiology and celebrating everything that there is to talk about being a woman in the field of interventional radiology and the lessons that we've learned from that, and we can share more widely with the whole of the IR community. I think one of our messages from today is that this isn't just about women, but we're here to champion those of us in the specialty and share that message widely. This is the 115th International Women's Day, and the theme this year was Give to Gain. It's an absolute pleasure, as I say, to be with some really esteemed colleagues, that many of whom I've known for several years in this field of IR. Let's introduce ourselves. Chloe, over to you.
Hi everyone, it's a pleasure to be here. I'm Chloe Mortensen, a consultant IR from Brighton. I do vascular and non-vascular IR, and until recently I've been there for about 8 years, and when I came back from my last mat leave in September, I joined my first female colleague, and I've had a few along the way, so that's really, really great. And I have 3 kids.
Chloe, thank you. Winnie.
Hi everyone, good evening. My name is Winnie. I've been a consultant IR in University Hospital Coventry for 4 years. This year I'm particularly happy because I've now got 2 female registrars with me. So we're often in the IR room and suddenly find that, okay, there's the whole girls group in the room. So I enjoy photography. So I'm one of the member of the Leamington Spa Photography Society. So I normally go to our society meeting on Tuesday evening, but today I'm here to enjoy my time with you all.
Winnie, thank you, and apologies to the photography group that they're without you this evening. Madhu, over to you.
Hi everyone, thank you for having me on. My name is Madhu. I've just finished my training in interventional radiology at Oxford, and I'm currently working on a period of grace whilst applying for a consultant job. I've been really lucky to have lots of female colleagues in IR, 2 consultants and 1 other registrar trainee, which has been absolutely brilliant. I've got 1 child, and I came back to work from my maternity leave almost exactly a year ago now, so I'm still navigating kind of the early days of making it all work.
Brilliant, thanks Madhu, that's great. Kat.
Hi, I'm Kat Harborne. I'm an IR consultant.
I'm just going to pause you there, Kat, because you are muted. Do you want to try that again? Nope, that's still not. We'll come back to you in a second. Sammy.
Hi, I'm Sammy Rostampour. I'm an interventional radiologist at Imperial College in London. I'm lucky enough to work with now 6 female IR consultant colleagues out of a total of 16, and we've got 4 female trainees and a few more coming through. I've got 2 children who I had whilst I was in training and worked less than full time during that time. In my spare time, the little I have of it, I enjoy tennis, cooking, and I've recently taken on an allotment.
An allotment, wow. Okay.
Because I don't have enough things to do.
Exactly. Wow, that's wonderful. Sarah, hi.
Hi, I'm Sarah Locker. I'm an advanced practitioner in interventional radiology at Royal Preston Hospital, specialising in vascular access and drainages. I've been at Preston for 20 years, so I've seen quite a bit of changed and throughout the time. I've had a few personal challenges, both professional. I've completed a degree, a master's, including prescribing. I've had 2 children, got married and moved house all in those 20 years. So lots of challenges along the way. Had the fortunate job of working with a couple of IR female consultants and registrars we see coming quite through, and they're getting more and more females, thankfully.
That's nice to hear. Yeah, great. Thanks, Sarah. Let's see if Kat has got some audio now.
Can you hear me now?
No, she doesn't.
I can.
Yeah, I can hear Kat.
can.
Yeah.
I can hear Kat.
Oh.
Yeah.
Okay, go for it, Kat.
So I'm Kat Harborne. I'm an IR consultant from Worcester. I've been a consultant for 2 years now, and I'm also the current chair of the BSIR EDI committee. So I have 2 children. I did most of my training less than full time when I had both my children during training. And apart from a 3 or 4 month stint with Winnie when we were both registrars, I have never worked with another female IR.
Brilliant. Excellent, Kat. Thank you so much. Well, we've got a few topics we wanted to talk about this evening. Oh, I guess I haven't introduced myself. Apologies, although definitely not as esteemed as the rest of the panel here. But for completeness sake, I'm Alex Barnacle. I'm a paediatric interventional radiologist at Great Ormond Street Hospital in London. I have been there for 20 years as a consultant, and we are a team of 6 with 1 other female consultant, my colleague Sam Chippington there. I had plenty of other female trainees in my scheme as I was training, but it was a female diagnostic radiologist who came in and did bilateral nephrostomies in a neonate on NICU when I was a paediatrician back in the day, who inspired me to do radiology and then IR. So there's definitely a female influence that got me interested in IR in the first place. I don't have children. I have 3 stepchildren, so I think I am navigating probably a slightly different period of life, thinking about driving tests and helping them organise their weddings, etc. at the moment. So quite a different phase of life for the family that I'm a part of. Excellent. Well, we have lots of things we want to talk about tonight together. Thinking on the Women in IR theme and International Women's Day, I might go over to Chloe to start with. Chloe, tell us a little bit maybe about what's great about being a woman in interventional radiology, do you think?
Yeah, I mean, I think loads of things. Let's talk about the quality of women, the quality that we bring, and the way that we can communicate. So some examples, just from the start of the day, being in the changing room, seeing the nurses and radiographers, just being able to have that kind of really informal relationship with them. And then sometimes the way that you can communicate with some of the patients, so the fibroid patients that I speak with, I feel like I can, communicate with them in a way that is kind of makes them satisfied and kind of trust that I get what they're talking about. And I think we can sometimes set examples of how to behave in certain situations. And also lastly, for me, being a mentor and being able to encourage people who were like you a few years ago, seeking examples of people who are doing it and are the same as you.
Yeah, absolutely. Yeah, thanks, Chloe. Madhu, what about you as you set out on the next stage of your career journey? What do you think has been brilliant about being a woman in IR so far?
I think a lot of things that Chloe has said I absolutely resonate with, particularly I think the kind of more softer skills, communication skills, etc. I think women do have a lot to offer in that, and it's really nice, particularly with patients who are coming in for a fibroid embolization or a pelvic vein embolization to be able to say I get that. Although I suppose our male colleagues probably have the same with, well, possibly have the same with prostate. I don't know. So that is quite nice, and it's also really, really lovely to, as you say, work in a team of mostly, I think, female nurses and radiographers, and kind of have that commonality where you can have a nice chat outside of a case. You can get along really well, and you really do feel like part of a team. So all of those are great things of being a woman in IR. I also think that kind of, historically, I think women have been the seamstresses and, are known for having kind of fine hand-eye skills and motor skills. So why not bring that to intervention?
I like that. Yeah, that's a great insight. Thank you. On that subject of nurses and radiographers in the IR suite, Sarah, what do you think being a female in this IR space, what do you enjoy and celebrate about that, do you think?
Yeah, I think because we probably, like most of them have said, slightly outnumber usually on the nursing front, the females. So we usually have that really great team sort of morale as well. But I have to say that the men at Preston do muck in with us as well and have a laugh with us as well and join in with everything that we've got. We like seeing the female registrars coming through. It's nice just to have, like Chloe and Madhu have sort of said, that softer touch sometimes with those ladies that need the fibroid, that sometimes look a bit daunted when a man with size 8 gloves walk into them and say they're going to start operating on them. So yeah, it's nice when we get the registrars, sometimes that bit of softer touch. We did have one consultant, unfortunately she's left now, so we've got a little bit of a gap for, I think, a female consultant at Preston.
Yeah, thank you. Kat, how about you? What's been your experience?
Yeah, I completely resonate with everything everyone else has been talking about. I think there's just about the room when it's an all-female team, and it's you can't put your hand up. Like, I can't tell you exactly what that is, but particularly for our very anxious patients. And I as a registrar in an all-male department, there were certain patients who were sort of steered in my direction or put on lists when people knew I would be doing that list. And I think actually, yes, that would have been an opportunity for somebody else to maybe work on their communication skills and things, but actually for that patient, it's really lovely, and it's such a privilege to be the person that makes that scary procedure, that scary space, feel a bit safer for them.
Yeah, interesting. Thank you, Kat. Sammy?
Yeah, thanks. I mean, a lot of what's already been said is kind of what I was going to say, but I think a couple of additional things. I think particularly the senior women in my IR department have been really exemplary in leadership, and I think that's brought a different dynamic to the team. I think a bit more empathic. Obviously, people have lots of things going on in their lives outside of work, and I think are quite adept at dealing with those things in a way that's, I think, quite different to how sometimes men deal with things. And then in terms of the delicate touch, I had a patient say to me the other day how delicate I was, and it is something that I really do try to be super gentle. And one of the nurses I thought was really sweet said, "Oh, that's what she's famous for." And I felt really proud that I do really take time in doing just the local anaesthetic really gently so that the rest of the procedure is really comfortable. And I felt really chuffed that had been acknowledged, and actually the nurses sort of say how soft I am.
Yeah, nice. Yeah, I really like that. There's a couple of things along those lines that resonate with me in the paediatric practice. I think with only 2 female IRs in the team, it is predominantly mothers who bring their children to clinics and to procedures, not always, but often. And I sense that there is a sense of them perhaps thinking that I understand their situation a little bit more. I might not, particularly me, I'm not a mother myself, but that there is a level of empathy there that I think that a lot of mothers feel. And increasingly we have quite anxious teenage girls, women, young women coming through the service who really don't want to be examined in the clinic by a man, or think they're going to be put to sleep for an operation and be operated on by a man. And just to have within our team that opportunity to be able to have options and offer some of that around is really helpful. The other thing, speaking to your point, Sammy, completely, is the leadership thing. So I think because there are far fewer women in IR, both just within our individual departments and in committees and leadership positions, it's very easy to stand out. And I take that to be a positive, that I don't have to try as hard as perhaps a man might who's one of 20 men on a committee. I don't have to try. I like to try and bring the positive to that I don't have to try and stand out and go the extra mile. I have that innate, just fortuitous advantage that I think sometimes we actually get an increased opportunity to speak up or to contribute because we are the minority in the room. It's not always the case, I get that, but often it is. And when it is, I like to exploit that advantage to the full. Yeah, interesting. Challenges. Tell us a little bit, some of you, about some of the challenges you're most proud of overcoming so far and what you've done. Winnie, a little bit about, can you speak to anything that you're particularly proud of in your career so far that you've done? Anything that you would reflect on if you were talking to your younger self and say, you know, you'd never have dreamt it, but guess what? This is where I've ended up being, or this is what I got done.
I think the challenges is that I have come through a relatively male-dominant kind of like career path, and so my background is I've done quite a lot of surgery before I joined radiology, and then I decided to do interventional radiology. So I've left one specialty which was quite male dominant, and I've gone into another specialty that's even more male dominant. And I'm still here, I'm still going. And I think there has been challenges throughout. That's often because you feel like you are a bit of a minority, and then when your colleagues start talking to each other, then they're not always that inclusive. So sometimes I did feel a bit as like an outsider, but I think along the way I've kind of learned at how to get myself involved, and I do be more proactive in talking to my colleagues, and then become kind of part of the group. So yeah, that's my main challenge of feeling different initially, and then to have to kind of make friends with everybody. And I do feel that I do have good relationship with a lot of my colleagues.
Yeah, great. Thank you. Sarah, what about you? In your long career at Preston now, what are some of the things that you look back on and reflect on and think that was pretty cool?
I think where I'm at, you know, with 2 kids and to have achieved a master's in prescribing, one of, you know, nobody's ever prescribed in IR at Preston, and I was the first person to get that prescribing right as a nurse, that now allows me to really run our day case unit, you know, be able to look after those patients afterwards, prescribe the painkillers they need without waiting on a doctor who's scrubbed in the room for another hour before they can come out and dole that out. We can give that holistic, really quite quick care straight away. We can run our own pre-assessment clinics. We can bridge therapy now with that prescribing right. And sometimes I think I used to look back and think, oh, right place, right time, or you were lucky to get that chance. And actually perhaps tell my younger self, no, actually you worked hard for that. You did work hard for that, and you actually maybe deserve where you've got because you did put the work in. I think, you know, it's sort of recognizing, sometimes looking back, you sometimes think maybe opportunities fall upon, and perhaps they do sometimes, but you've also worked hard to get there as well. And I'm sure all you guys have worked, you know, for your training really hard to get where you are. And it's recognizing actually it's not just luck that you've got there, you've put that effort in to be able to get there.
Yeah, agreed. I think that's quite common, isn't it, that we tell ourselves that you know, oh, we ended up here and weren't we lucky? But there's a lot of hard graft that goes on in the background for everybody who works in our specialty, of course, but it's easy to forget that stuff as you go. I think we raise our standards continually, don't we? So we forget that what feels like a second nature thing to achieve or to do now, to give a talk or to do prescribing or to lead a team, might come as second nature now, but that would have been almost impossible to have imagined many years ago. Sammy, what about you? What are some of the challenges, some of the harder things that you think you faced in your career to get you to where you are today?
Probably not specifically about my career, but one of the things that I never ever thought I would do was public speaking. I had really severe anxiety, particularly as a teenager, and the thought of speaking in public, I would be vomiting, basically. I would be that anxious. And my mum sort of encouraged me to do some public speaking, and it was horrific. So to force myself to agree to speak at conferences and run courses and things was actually something I found really hard initially, and had to work a lot on that. So to speak at, say, Cersei is actually an enormous thing. I lose a lot of sleep prior to it, but it is improving. So I never thought I'd be good at public speaking.
Yeah, really interesting. What are some of the things that you had? What are some of the top tips for us that get you there?
Say yes when you really want to say no.
Yeah.
I guess I'm a massive over preparer. So the amount of time for the initial talks that I would give would be ridiculously out of proportion to the number of minutes. But I guess that gave me confidence. I think it's a huge imposter syndrome, really, is what I had. But couple that with severe public anxiety, and it's not a great combination, but I'm definitely getting better at it, and maybe not the speaking, but feeling less anxious about it.
Yeah, so it's not second nature to you. It's still something that each time you have to challenge yourself to do.
No, and then compare that to today. I've done a branched thoracic aortic case, and I don't find that majorly stressful. I'll lose a little bit of sleep, but it's just such a weird contrast that you can do crazy things, but something that other people don't find, I guess, worrying. Speaking in public is something that's been a major hurdle for me.
Yeah, and you touched on imposter syndrome there, which I think is far commoner than we talk about, yeah. Right? For men and for women, it's not just a female thing at all. Chloe, do you have any comments on the whole imposter syndrome side of your career?
I'm definitely a member of the imposter syndrome club. How's that going for me? I think it gets easier with time, and it's a confidence thing, isn't it? And your confidence can go in waves throughout your career. You know, sometimes you feel like it feels easy, and then sometimes it feels really hard. And so imposter syndrome is something that I feel like I've shaken off sometimes, and then sometimes it will just suddenly come flooding back, and I'm like, man, I thought I'd lost this thing, because it's really annoying and really unhelpful. But I think it's common. And I think I just kind of acknowledge it and then try and ignore it, basically. And also don't give myself too much of a hard time about it. Like, it's not that big a deal. You feel like you might be a bit rubbish, but you're not, because you're there. And until someone tells me I'm rubbish, I just need to believe that I'm not. It hasn't happened yet, luckily.
Yeah, I think I've read in a few places where, you know, for anybody who's striving to be better and wanting to be good at what they do or at some particular thing in their life, if you believe that you're not there yet, that's all part of the process. And if you didn't have a degree of imposter syndrome, you wouldn't be one of the strivers. So I try and think about it, reframe it a little bit like that, I think. But yeah, the going in waves thing is definitely, I guess, I'm the whole menopause aspect of life brings all of that up again, oddly. where I am in my career, there are several much younger consultants in our group who are, you know, fired up with enthusiasm for IR, really expert with their clinical skills and really up to date with their knowledge, and have this real passion to set the world on fire, which is not always the position I find myself in day to day. And that's an interesting challenge in the team. You can feel quite easily, it can feel like you're being sidelined, or that you're less relevant, your voice is less heard or less relevant in the team dynamic, which is not how it is meant at all, but it's easy to talk yourself into that. And somehow it's almost like a reverse imposter syndrome maybe in there. I'm not quite sure how I would frame it, but it's another unhelpful framing mechanism that I have found has crept in recent years, and I've had to sort of find ways to reframe, or just, as you say, Chloe, just ignore it. Yeah, interesting. Madhu, how about you? What are some of the challenges that you've had, or things that you are really proud of so far?
I'm just going to pick up on the imposter syndrome thing, because this is something that's been super relevant to me in the last few weeks, with kind of stepping up to doing independent lists and feeling like, you know, the buck stops with me. And it's so difficult, because I feel like I spend a lot of time thinking constantly, oh gosh, not really sure if I'm making the right decision there, and the kind of internal torture of, you know, shouldn't I stand, what would X person do, what would Y person do? And it is so funny to think how a decision that, you know, would have been felt quite straightforward a couple of months ago, you run it past someone else, you go ahead and do it, is now kind of full of so much second guessing of yourself. I really like the way, Alex, that you reframed it as striving, and I'm going to try and kind of take it as a positive. I'm sure everyone, men and women, go through this at different parts of their career, and I'm sure it waxes and wanes, but as you say, looking at it as a positive is the way to take it on.
Yeah, I think so. Kat, how about you? What are your thoughts on this? I'm always interested to hear your take on these things.
So imposter syndrome, yeah, absolutely. And I can really relate to Madhu's comments. I think people always talk about kind of when you're in your first couple of years as a consultant, it's another really steep learning curve. And I feel like I'm slowly coming out of that now. I remember talking to a senior female IR at a conference, someone I really admire and look up to, who is very well known in the IR community, and we were just chatting about roles and things that she was doing, and it became very apparent that this person that I, you know, basically worship the ground she walks on, has imposter syndrome. And I was saying, oh, I'm just really lucky to have done this, and oh, I was just in the right place at the right time. And I sort of thought, wow, if she can get imposter syndrome, then it must be normal. And it's something that everybody suffers from. I think the difference is that women are more vocal about it. And I think certainly, you know, I've worked with a lot of male IRs, and I think there's almost a bravado, or almost like a laddish type behaviour, where they actually don't want to admit that vulnerability. I think as women, sometimes we have it easier. Yeah, I think it's. I mean, we could do a whole 1 hour session on imposter syndrome, couldn't we? I think it's fascinating how we can get to this stage in our careers where we've, you know, we're experts and we've gone through training and done all of these things and do all these, you know, amazing procedures, and yet we still think, oh, am I good enough, or am I a bit rubbish actually?
Yeah, that is interesting. Absolutely. I think maybe different people manifest it differently. So you don't know that everybody is actually going through it. And maybe it's best to just assume everybody has it. They're just not talking about it, or that they have had it at certain points in their life, I guess. Chloe, tell me, if you were feeling undermined at work, or you were feeling less than less than at your best, or have you had episodes where you have felt undermined or harassed in your job, either as a trainee or more recently, or maybe outside of work, and how you sort of reframe that or work your way through that?
Yes, I have. It was as a trainee, just not brilliantly supported, and I think as a result I sort of slightly fell behind and lost confidence, and the mentors that I'd had, they were fabulous male mentors, were sort of near retirement and sort of disappearing. And so I lost those figures as mentors, and I just ended up having to be quite honest, and say, I mean, it was difficult, but just say, you know, look, this isn't great, you know. I spoke to colleagues, but ultimately I had to say, this behaviour is not okay, and it needs to be changed. So it was quite confrontational, but I think what it resulted in was a kind of a mutual discussion around how a working relationship, training relationship, could be better. So instead of it becoming a kind of a passive aggressive kind of thing, we got it out in the open, and things were much better after that. So I think ultimately, and it took a while to get there, but I think just being really honest and communicating really helped me in that situation. But it's tough. It's tough to do that. So
that feels like a really brave thing to do.
Yeah, I'm not saying that's an easy thing for everyone to do, but ultimately that's the thing that worked.
Yeah, I like that about it, that how these things can evolve into a passive aggressive situation, or just this unspoken weight or freight of the situation that you come into day after day. And maybe in this country we are less good at just being open about those conversations and lancing it and getting on with it. Yeah, I agree. Kat, I think you've had some challenges in your training as well. Is that fair to say, in terms of, you know, being the only female trainee on your scheme, and there were situations that were quite tricky for you there?
Yeah, so when I first started my IR training, I think I was the only female, and then Winnie started training and overtook me very quickly. I went on mat leave, and I was less than full-time as well. I was the first less than full-time IR trainee in my deanery, and at that time we had no female IR consultants at all in the whole deanery. There were a lot of challenges with being a less than full-time IR trainee. I think the perception is that when you are less than full-time, you are lazy. You're not seen as often as the other trainees, and so the assumption is that you're not doing as much work. And you know, I knew that I would over the years do as much work as everybody else. But if you're only working 3 days a week, and then the consultant that you're with has an off-site day or something, so they only see you once that week, the perception is you're lazy. I can remember a really, really difficult time in my SD6 year, when my husband, who's a gastroenterologist, was on call. So he was consultant at that point. He was on call, and we had that dreaded telephone call from nursery to say, your son's been sick, you need to come pick him up, he can't come back for 48 hours. And you know, I had to cut and run because my child was sick and I have no nearby family. And the amount of grief I got from colleagues for not having anybody else to pick up my poorly child, or for not having a husband who could go and leave his job to do that instead, was really hard. And it made me feel very much like I wasn't part of the team, and like I was the weak link. And I think it's really difficult when you compare yourself with other people. And I was, at the time, the only female registrar, and all of the other people on the reg rota, none of them had children. Most of them weren't married. And therefore they lived, around the corner from the hospital, because they were able to rent somewhere around the corner from the hospital and basically be there all the time. And so that was really, really tough. And you asked earlier about what's the thing that you are really proud of. And I think overcoming those kind of difficulties and putting my head down and just getting through training and doing what I needed to do in that often quite difficult and toxic environment is something I'm really proud of. I very nearly didn't complete IR training. It was really, really tough, and I'm really grateful to the mentors that I had around me, none of whom are IRs, the people who sort of championed me and supported me to get through training, because it was really hard.
Yeah, Kat, thank you for sharing that. Yeah, that sounds tough. And I think particularly if you are one of the first in a cohort to have children or to be less than full time, in time everyone or most other people are going to be going through that experience, right? But at the time it's novel to them, and it's all of those things that down the line will become increasingly sharply in focus are not other people's experience. So yeah, well done for working your way through that, and how brilliant that those mentors were there for you to support you on the way. Being an ally and a mentor in this kind of professional space is so important. And Sarah, I was thinking about that with you. You must be at the point where you are in your career, with a whole bunch of younger female nurses and radiographers coming up through the team. And often the IR suite is quite a high pressure environment, and that's putting it mildly, I'm guessing. And none of us are always at our best in that kind of high pressure, high stakes environment, or when things start to go wrong. Have you had times when you've had to be an ally for some of your more junior colleagues, or speak up in the room on behalf of colleagues, or help with dynamics when things have got difficult?
Yeah, occasionally we sort of, when, like you say, you get new onto a training and may make mistakes or be not as fast as the older ones who are more used to kit and that kind of things. But I'm actually finding a bit role reversal now. I still do on call, but because I do my own lists, when I have to come in for an EVAR, I sometimes look at it thinking, oh, this is a new one on me. And I have to look at the younger nurses to say, which port is it we flush on this one? Which bit is it that? And it's actually gone a bit role reversal, that I've definitely got imposter syndrome, although they look at me as the experienced nurse with 20 years. Because I'm not exposed to the rooms as much, I'm doing my own lists elsewhere. The bog standard sort of kit that comes through now is sometimes a bit of a challenge. So I think the newer ones quite like that when I have to ask them for advice, because I feel a bit like they can, brush off, or she needs help then. But yeah, we have had to pull some of our consultants and say, you need to give them time. It's not a quick fix in IR. The training takes time. The amount of kit we use, the amount of wires we use, all the fancy things we're bringing in now, the Shockwave, the Jetstream, the numerous products that are coming out. It takes time to train those nurses up. And Preston, we have sort of 2 IR suites plus a hybrid plus a recovery bay, and we rotate our staff, which is great, but it also sometimes then can hinder their training on these more complex kits. So we sometimes have to pull our consultants up a bit and say, cut them a bit of slack, give them time, and they will get there. But the more you beat them down and criticize them isn't going to help the situation at all. So yeah, but sometimes a quiet word with them is all that's needed, rather than anything big dramatic.
Yeah.
And they often can really think, yeah, perhaps I was a bit short then, or and they sometimes start reflecting a little bit, I think, on what they've sort of said. But
Yeah, absolutely. Yeah, I think it's so important to remember that there's lots of people in the room. I think as Madhu was reflecting on, and we've got 3 or 4 advanced practitioners in our practice, and I do some work with them. We do some simulation training together about just speaking up, and how, as an advanced practitioner, how do you introduce yourself at the team brief? How do you stand up to challenge when someone says, oh, can you go and get the consultant now? When it's actually your own list and you're perfectly competent to do the procedure and work it through yourself. And I think that's interesting. It's something that maybe as doctors we see modelled from the get-go as medical students, but that nurses and radiographers see less of. But equally, as junior IRs, either as trainees or junior consultants in the suite, we might forget that we are surrounded by radiographers and nurses and healthcare workers who can equally be our allies in that situation, and some of whom have been there 20 years and seen it all before and understand the dynamics in the room.
I found it quite a compliment the other day. The consultant said the registrar wanted to learn 2 lines, and he said, well, you best do one with Sarah because there's no good me showing you. And I thought, I'll take that. That's quite a compliment, you know, that they feel that, I suppose, you know, they recognise that in us, and that as advanced practitioners, you can take on those training roles, and you're perhaps exposed slightly more to the more, I suppose, the straightforward things. But I never say lines straightforward anymore because we get caught out with those, don't we? But you know, they're often left to me to do, so I probably do the majority. So therefore, the, you know, the training, perhaps they look at us more to come, the consultants. That's quite nice.
Yeah, really nice.
It's just working as a massive MDT team, though. I think that's hugely important. You know, that we're probably one of the biggest MDT mixes within a room at any one time in IR, because we've got the radiographers, we've got the support workers, the nurses, the consultant.
Yeah.
Most specialties don't really have that dynamic in one room at one time. And then you've usually got a specialty coming to the door asking you to do something else, and a nephrostomy whilst you're doing something else. So, you know, that dynamic in the room is really important, whether that's males, females, or whatever. But I think that MDT team is hugely important.
Yeah, absolutely. I agree. And I think some of us have talked before in this group, preparing for this evening, we talked about how we've got additional allies more widely in the hospital, haven't we? Our female or male vascular surgeons, urologists, general surgeons. There's an even wider pool in the hospital to support us in what we do. And sometimes those are the people who it's nice to turn to step outside of the team for a minute. You can be a bit more honest sometimes with them than you can be with people that you might feel you need to be a bit more professional with. You can go and have a cry or a moan with someone else outside of your team, and it doesn't seem to matter quite so much. Yeah, interesting. Madhu, how about you? Who are some of the allies or the mentors that have supported you in these first few years of your career?
So I'd say that probably the biggest reason I ended up going into interventional radiology was, at that time, an ST6 and now a consultant in Oxford who was also a female IR, who I massively looked up to as a junior trainee, still massively look up to, and has always been an ally in that way. I think going back to what Sarah was saying about the MDT, it's amazing how helpful nurses and radiographers can be. I remember doing a transplant nephrostomy as an ST4 reg, and not being able to get my microaccess needle through the renal capsules, trying, and one of the nurses pipes up from the background saying, you know, Dr. Boardman used a Kellett needle when this happens. And I was like, brilliant, thank you. And it is amazing how people help each other out in that setting, isn't it? I would also say that on the whole, I've had many diagnostic radiologists who've also been great allies.
Yeah.
Understanding that, you know, it is really difficult to keep up your diagnostic skills when you're an IR trainee, and, you know, making space for me to cherry pick and learn from their cases, and you know, make the most of the little reporting time I've had. So yeah, I would say it's not just come from within IR, but also from diagnostics, nursing, and radiography.
Yeah, absolutely. That's such a good point. We're also part of a much bigger team. Radiology is often one of the biggest teams in the hospital, isn't it? Actually, if you look at the size of the whole department. So we've got extra people there for sure. Chloe, I think, did you say you've got 3 children?
I do. I've got 3 children.
Wow. Can you tell us a little bit about that whole, how that has maybe shaped your career path a bit differently, and you know, the being off, the coming back, the being off again, and then the juggling, having children at home? That sounds...
Yeah, I'll try and be brief. I had them as a consultant, actually, and I don't think it's ever easy to have kids at any point in training, but the things that were specifically quite tricky about having kids as a consultant is, like, you kind of jump off this cliff when you become a consultant, and Madhu was talking about it a bit, like that massive jump in responsibility, which is really, really hard to imagine before it happens. And so I think there's a reasonably steep learning curve in experiencing that, and the imposter syndrome and the confidence to make decisions. And so in the last 8 years, yeah, I've had 3 kids, and I've taken between kind of 8 months and most recently, I think it was 14 months off. Operating till reasonably late in the pregnancies, but still, that's a huge chunk of time to not have patient contact. And I thought I had finessed the art of returning to work. I set it all up, thought really well about it, reflected on the previous experiences, like, I'm not going to do that, I'm going to do that, this is just going to be great, it's going to be fine. And of course, it's been the hardest to return to work, you know, out of all 3. And I'd say, you know, I haven't overcome that challenge at all, and I'm still experiencing the return to work kind of challenges even now. And so the logistics of coming back to work, I think, are the easiest thing. It's getting the confidence back, it's the decision making. Okay, I've got 5 decisions that I can make in this particular moment. I know how it feels when I'm feeling confident. I just make a decision, I'm okay with that. Right now, I'm paralyzed with that kind of second guessing. And that is that's just a confidence thing that is obviously going to happen if you haven't been doing it for a while. So I think it is really hard. And I think my mistake was thinking that I could make it not hard. And the reality is that it is. And you have to be really open and honest about where you're at. And I think this is another brilliant thing about being a woman, is that, you know, I think that I'm able to inspire an ethos and a culture within my department of, you know, actually saying I need extra support, having a low threshold for saying, like, can I have a sense check on this, and making that a normal thing. And I think that's something that I will use to my advantage, and hopefully that will kind of rub off a bit on everyone else. It's just like, it's totally acceptable to, you know, to discuss cases with everyone, and actually everyone's really, really glad when you do that. So
Yeah,
still works on it.
That's so interesting. Yeah, thank you, Chloe. That whole making, I like that phrase, can I sense check something with you? That isn't suggesting, you know, that you're wrong or that you might have made a mistake. It's just exactly what it says on the tin. And yeah, that's a really helpful phrase to use.
And just a very brief kind of final thing. It's what I've tried to really work on, is to not be apologetic about the situation I'm in, and to own it. And the sense check is kind of, like you say, it's a nice phrase, because, you know, like, it's okay to be like that.
Yeah, absolutely. I maybe it's slightly the other end of career wise. I think a lot of women, more than men, or evidence, the data shows that more women than men end up in carer roles later in life as well. And I cared for my mother through dementia for several years until 2 years ago. And I found that really hard, being at work and feeling like I wasn't focused. I wanted people to ask, and I didn't want people to ask, all at the same time. And I felt I wasn't operating in any sense at my best. And I remember going into quite an important meeting that had been planned for quite a long time with our anaesthetists around challenging behaviour, and we knew it was going to be a difficult meeting. And the day before was the first day my mother didn't know who I was. And I got halfway through that meeting and cried and had to leave. And I beat myself up for about a year after that, thinking that I had let myself down and been a girl over the whole thing, and all of those unhelpful things that we tell ourselves in conversations. I think we never know what other people are going through, do we? And the challenges that they are bringing to work, or the lens in which they're seeing things, and having that kindness to support people and when someone's expressing doubt or asking for some reassurance and support, to just be there and not question it is really important. Yeah, thanks, Chloe. Sammy, some people have put some questions in the chat, and we've only got a few minutes left, but thank you to those who have sent us some questions. Sammy, I thought I might ask you, because I think you said you had your children while you were still a trainee. Maybe that it was a bit more of a challenge for you to frame those questions, or the answers to those questions in your head, around radiation protection for women in early years. When you're going into interventional radiology, there is some negative chat around radiation exposure and adequate protection, and you would have had that extra burden of thinking around that and pregnancy.
Well, actually, I had my children before I started my IR training, but actually there's so much misinformation that even I was advised not to screen and do fluoro, bariums and things like that, even despite the fact that you stay behind the room. So there's total incorrect info. But I've had a trainee and now a consultant colleague who's had, and two consultant colleagues who've had children and pregnancies and done IR. And in fact, one of my colleagues has just left on maternity leave today at 38 weeks and has been basically doing full IR that whole time, amazingly. So I mean, there's they've no longer advised to do live TLD readings, but they've given her extra maternity leads, which is a really lovely little apron that goes, so you don't need to double lead if you choose to. Obviously, we've got all the lead screening, and we all wear lead glasses. So I think there's a lot of misinformation. What you're advised to do is basically just go and speak to physics teams, look at the kind of cases you're doing. And I think a lot of my colleagues have found sometimes it's the physical aspects of being heavily pregnant is harder than doing long cases, leaning over. So it's entirely personal as to what you are able to do. And maybe Chloe, actually, you've probably got more experience of that than me, because I wasn't pregnant during my IR training.
Chloe, did you have anything to add to that?
Not really, no, as Sammy said. And I think, I've worked in an incredibly supportive environment where people have just said, look, just do what you're comfortable with. So I found a really good lead insert. The nurses were all so lovely, on call. If I had vascular surgeons who were just like, they'd just stand in front of me quite a lot, but they just check in on me, like they were just, it's just knowing that you are supported and you can make your own choices. I was under no duress to operate up until a period of time. That's just what I wanted to do. So I think you can write your own recipe a lot of the time, and you should feel that you can.
Yeah. Thank you, Chloe. We've had another comment or a question posed to us in the chat from our colleague Siwa. Winnie, I might bring that over to you. She's asked, through your lens or our lenses of lived experience, what would we share with our younger selves looking back? What would you say to you if you think back to when you were thinking about radiology or interventional radiology and the doubts or the questions you had then? What would you say to that person now?
I think with regards to interventional radiology, definitely no regret. I changed my career path from surgery to radiology. I'm really happy with my choice. What I would really like to say to my younger self is that I think throughout the training and throughout my career, I had severe imposter syndrome. And then I often find that I'm achieving something, but then I don't even remember that I have achieved something. I have to be reminded by other people. And my friends would say that, oh, well, Winnie, you've done really great. Why are you not so confident? So I often get reminded by my friends, my colleagues. So I would like to say and then as a result, because I was not aware of my achievement, I just spent more and more time in career and in work. And then I kind of like missing out that I don't go out so much with my friends. I didn't spend a lot of time with my husband. And then, I basically have work, and less social time. So I would really like to say to my younger self that be confident and you don't need other people to remind you how great you are. You know what you have done, what you have achieved, and just be confident and enjoy life, and as any other people, and spend time with people that you really treasure with.
Yeah, absolutely. Winnie, thank you. Madhu, what would you have to say to someone who was thinking about going into interventional radiology at this point, male or female? What is it about it that inspires you and should inspire others?
Oh, absolutely, go for it. It's the best job. There's so much variety. We deal with so many body systems, so many other specialties. We can also report. It's just such a great mix in a week, isn't it? When you can do something in angio one day, you can do a clinic another day, you can report another day, you can go to MDT. I don't think there's many specialties in medicine where you get that variety. So I would just say go for it. It's brilliant.
Yeah, absolutely. Yeah, that's great. And even just with those of us in the room here, I think we all work in quite different team setups and scope of practice and size of department. There's all of that. Certainly, you know, there isn't one size fits all for what interventional radiology looks like as a career, for sure. I agree. Someone has asked in the chat, what changes would we like to see to make interventional radiology more inclusive and supportive for women in the future? Which is a beautiful segue into what we wanted to talk about before we close tonight. Looking towards the future, what opportunities are there out there for women and men in IR in the UK and perhaps more widely? Well, there are lots of initiatives that we wanted to share some information with you about tonight, and we will put some links to some of those in the chat afterwards. Most notable amongst those, I think, is the mentorship program that's running at the Royal College of Radiologists that's now in its second year. That's overseen by the Equality, Diversity and Inclusion Committee of the BSIR, who have set that up and piloted it in its first year. That is a mentorship program that's open for ST4 to ST6 trainees who are paired with a consultant for a year, I think it is. Kat, is that right? And you can really make of that year what you want. So it's up to you sitting with your mentor to think through about how you might want to best use that year. It's a fabulous opportunity and a really successful program that's really getting started now. So I'd encourage people to look into that if they are looking for some mentorship in their career. Secondly, we're really proud of the Royal College of Radiologists and BSIR Ambassador Programme for Women in IR. Please take a look at the link we will put in the comments later, or head straight to the BSIR website, where the gallery of women in IR is. There's a whole bunch of us who have put ourselves up there with our different experiences in interventional radiology, for people just to remember and appreciate that there are loads of us out there on the days when it's hard to remember that. And you've seen one too many manels at a conference or at a meeting, and you want to remember that there are lots of fabulous women in interventional radiology out there as well. And you can reach out through the BSIR for a one-to-one, one-off conversation with one of the ambassadors if you have some specific questions that you feel they might be able to give you some insights on in your career. We are just kicking off, we're just about to kick off a program between the Society of Radiographers and some interventional radiologists, looking at how to make the IR suite more inclusive for women, and trainees and consultants stepping into the IR suite in the first few years of their career. I think there are lots of things we could do to make that a less daunting space. And we're working with the radiographers in helping us to champion that space within radiology and make it an encouraging space to step into rather than an intimidating one. And finally, Sammy, I know you have set up a program supporting return to training. Can you tell us a little bit about that?
Yeah, I took it over and we've been running it for about 7-8 years now. So it's a return to training course for radiologists. We do, so it's for London trainees initially, but we open it out nationally if we've got spaces, and it's run 3 times a year. And essentially we offer a refresher for emergency neuroradiology. We have a psychologist, and we signpost to all the resources, and it's a free course that is run. I think we've got the link to it, and we've got one coming up in a couple of weeks' time. We run them normally March, June and November, and I share that with the Deputy Head of School for London School of Radiology. And yeah, it's quite a nice day. And it's not just for people coming back off maternity leave, it's people who've had any form of career break for research, illness, or anything really. If you've had more than 3 months out of training, you're eligible.
Fantastic. Sammy, thank you so much, and thank you to everybody for a great conversation this evening. I have really enjoyed it. Thank you for all of your insights and for sharing some really quite big stuff about how we've got to where we are in our careers so far. It's always a pleasure spending time with you lovely ladies. And thank you to all of those who have joined us online live tonight or are watching this later on. I hope you found this really helpful and inspiring. I'm sure so many of you have got stories that you could share with us too. Please feel free to put some of those comments or questions in the chat. Some of us will stay on afterwards and answer those in the chat if we can. And please reach out to any of us through those channels that we've talked about before, or if you see us at upcoming meetings within the UK or the wider IR community. Thank you so much. Have a wonderful evening and good night.